first Dr. Helene Calvet. She is the Deputy Medical Director of Communicable Disease Control Division, Orange County Healthcare Agency. She's board certified in infectious disease and internal medicine. Helene started her career in academic medicine and moved into public health for the last 20 years with special emphasis on sexually transmitted infections and tuberculosis. From 2012 to 2018, she served as the Deputy County Health Officer for the Orange County Health Care Agency. She cut back to part-time in 2018 in order to volunteer in global health, but in March of this year, she returned full-time to assist with COVID response. Helene has published 10 articles, served on 2 CDC expert panels, and taught STI management to healthcare providers throughout Region 9 and 6 other countries. Countries. Helene earned her MD at UCLA School of Medicine. Helena?
So good morning. Prior to this pandemic, I was happily working part-time in our STD clinic, enjoying doing lectures and had a pretty nice life. And that has totally changed in the last 3 months. I'm exhausted. I'm dealing with many, many outbreaks of COVID. And so I'm happy to take this little break to talk about STDs. The county itself really doesn't do a lot of reproductive health services per se, but we are under regulation and control of doing STD control. Next slide, please. So just to give some national context, I'm sure you're all well aware that STDs have been rising significantly in the last 10 years and really more rapidly in the last 5 years. Gonorrhea and syphilis were both at really historic low levels back in around 2000 to 2010. And now have increased substantially and are at the highest rates in more than 25 years. And very unfortunately, there's been a resurgence of congenital syphilis cases, and we'll delve into each one of these a little bit more. But this infographic from the CDC website shows you that nationwide, chlamydia has increased about 20% since 2014, gonorrhea 63%. Primary and secondary syphilis, about 71%, and congenital syphilis has had a really huge rise. Next slide, please. So the state, and that's the state of California, for STDs, it's like every place else. We're kind of always seeing the same increases, but a particularly alarming rise in syphilis that is now starting to affect women and infants. As you can see in this graph, how since 2012, there have been over 100 infants who have been lost to congenital syphilis, and the situation is really not getting better. We'll look at this in a little bit more depth. Next slide, please. So all 3 diseases on one graph. As you see, chlamydia has had kind of more of a steady increase. It never really was low, and actually you see it rising since 1995, because that's about the time we had a change in diagnosis, had the nucleic acid amplification tests, which are much more sensitive. And as those were rolled out and more testing was done, have been seeing a fairly steady increase in chlamydia the whole time, with the last 5 years maybe being a slightly higher slope. Gonorrhea, we're at fairly low levels in 1999, 2000, had a little increase around 2005, went back down, but now has had more of an increase. And syphilis is hard to see on this slide because of the axes, but we'll have one that points it out better. I'm focusing on early syphilis. That's primary, secondary, and early latent syphilis, because those are the most recently acquired cases. So the ones that are contagious to others, and are most likely to have effects on a pregnancy. Next slide. So chlamydia, you see that there's always been kind of this gap between the rates among men and women. If you actually look at studies that have done community-based surveillance where everyone gets tested, those numbers are much closer. So this is somewhat a testing phenomenon where we're finding it in women more because they're coming in for their reproductive health visits and getting tested for chlamydia, whereas men really don't have that same sort of point of contact to be able to be tested for it on a regular basis. Next slide. What's really concerning about chlamydia in women is the reinfection rate. And these slides, by the way, are from the California Department of Public Health, the most up-to-date slides they have. New ones, who know if they'll be coming out this July or not, the way things are going. The reason why we're concerned about repeat chlamydia infections is because in women, if they get repeated infections, these oftentimes can be asymptomatic, lead to chronic inflammation, scarring of the tube. So a woman that has had 2 or 3 chlamydia infections has a much higher risk of getting PID or tubal infertility. And that's why the repeat screen, any woman that is diagnosed with chlamydia should be rescreened for it in about 3 months. So here we see from 3 different data sources, the case reports, managed care, and family planning, that anywhere from 9 to almost 20% of women get it back within 6 months. So that's a very concerning statistic. Next slide, please. So gonorrhea, as I showed before, kind of at low rates, 1999 to 2000, little bump, came back down, but then has been increasing really since about 2010, and increasing more in men than women. So men tend to have about a 2-fold rate that women have. Next slide. And like chlamydia, repeat infections are not uncommon. It's not quite the same level as chlamydia, so running about 4 to 6%, but again, repeated infections hold a higher risk of adverse reproductive health outcomes. Next slide. So this is syphilis, and we were at a historical low level in 1999, at which point the CDC launched their syphilis elimination campaign. And I like to joke that nothing pisses off a bacteria more than trying to eliminate it. So it immediately started rising again. But that initial rise around 2000 was predominantly in men. And it really isn't until the last 5, 6 years that we've started seeing it in women. I mean, I've been doing STDs all along, and we just didn't see syphilis in women until really the last several years. And both men and women at this point are well above our 2020 objectives. Next slide. So when you look at that rise, kind of break it down by the gender of sex partners, you can see that initially in the first 10 years or so of the syphilis resurgence, it was mostly in men who have sex with men or men who have sex with men and women. And it's really just been in the last 10 years or so that we've started to see it getting into the men who have sex with women population, or the heterosexual male population. So when you see that, that's when it starts to hit the women. So women just started really seeing increased rates around 2012. Next slide. So this is the breakdown of the gender of sex partners. So about 55% are in MSMs or MSMWs. About 30% in heterosexual men, or men who have sex with women, and 15% in females. And this is a very different graph than what I showed. I do STD lectures on a regular basis, and so this looks very different than the graph that I would show, say, 5, 6 years ago during lectures. Next slide. This is our congenital syphilis rates, and I'm going to say a little bit more about this, but just to point out that California has more than twice the rate of congenital syphilis than the rest of the country. Next slide. So this is a very scary looking slide where you see that congenital syphilis has increased almost 10-fold since 2012, and it probably has by now. It doesn't have the 2019 data on there yet. There's a little bit of an explanation for this, though. There was a change in the case definition for congenital syphilis around that time, so that does account for some of this light pink area. Basically, if a woman delivers a baby and she has a positive syphilis test and we cannot verify that she was treated, oftentimes we'll have patients who say, yes, I've been treated, I was treated in this state, I was treated in another country. If we can't verify that treatment, that infant is labeled as a congenital syphilis case. So the good news is that the vast majority of these cases, these 329 in 2018, were ones who had no signs or symptoms. And and now those signs and symptoms can sometimes happen later. So those infants obviously have to be followed over time. But the real concern is the sort of lavender, the dark lavender, and the sort of rose-colored, darker rose-colored at the bottom. Those are the ones who clearly had symptomatic congenital syphilis. So as you can see in the very bottom line of the slide, there were 31 who were born alive with signs of congenital syphilis, and unfortunately 22 infants that were either stillborn or died in the early neonatal period. So these are completely preventable deaths. If these women can access care prenatal care, have the appropriate testing, the appropriate treatment as early in pregnancy as possible, then this outcome is totally preventable. Next slide. So how has the county responded? First, I'm going to say how the county was responding to just the increase in STDs. And I think some of the following speakers may speak to that, because some of them are the ones that have been helping us in this response. So we have one public STD clinic at the Orange County Healthcare Agency at Santa Ana. There's no way this one clinic can handle all STDs, but testing and treatment of STDs is really pretty standard. Any primary care provider can screen for gonorrhea and chlamydia, can treat gonorrhea and chlamydia. So we really rely on all those primary care providers and reproductive health providers out in the community to do the bulk of that. What's difficult is syphilis. And now, since syphilis has been resurging, a lot of providers are not used to dealing with it, don't know how to deal with it, and so don't have the medications, or requires a long-acting form of penicillin that many clinics don't stock. So many, we really see our clinic as being the main source of referral for evaluation and management of syphilis patients. We certainly do see a lot of gonorrhea and chlamydia, no question about it, but that's kind of our bailiwick is a syphilis. So to help us with some of this testing in the community, again, a lot of the gonorrhea and chlamydia increases were seen in men who have sex with men, or MSMWs. So several years ago, we recruited some community partners who had long time been doing HIV testing for us, and got them set up to do more complete STD screening. So they were able to do testing for syphilis, self-collected gonorrhea and chlamydia specimens from extragenital sites. All those specimens were run at the health department free of charge. So that was set up with 3 community partners. We instituted a quick check, walk-in sort of thing, just so that we could see more patients at least one afternoon a week. Didn't require an appointment. And we were planning to extend our hours to nighttime and weekends, but then the pandemic hit. Next slide. And so this is what's happened during the pandemic. So you can see the first sort of 2.5 months, or about 2.5 months of the year. The red arrow indicates when the stay-at-home order was put into place. So for those first 2.5 months, we were running about 122 patients seen per week in the clinic. And since that time, it dropped down, quite a lot initially, and even further. So at this point in the last month or so, we have been only seeing around 60 patients per week. So patient visits have dropped by half. Next slide. These are the early syphilis reports. And again, the red arrow indicates where the stay-at-home order was put into place. Now, syphilis takes a little bit longer to, doesn't take long to report, but it takes a while to figure out, to have it staged. So before that report is finalized as a case of early syphilis, it's a several week lag. So you see that for 2 weeks after the stay-at-home order, we still had kind of regular numbers of syphilis being reported, but now that's dropped down again by about half. Next slide. These are the gonorrhea and chlamydia case reports by week. Not the same issue with syphilis. Those are, we get a report, it's a report, and the vast majority of these are reported by outside providers. But you see for the first part of the year before the stay-at-home order, we were averaging, oops, my thing is not showing up here because it's cut off, but it was 265 cases of chlamydia reported per week, and I think it was about 93 gonorrhea. And then since the stay-at-home order, the average have both dropped by more than half. Next slide. So what we did in response to the pandemic, we had still kept open 3 full-time providers providing full STD testing and treatment for symptomatic clients, but we did stop performing screening for pharyngeal gonorrhea and chlamydia because collecting those specimens can lead to a possible exposure event if someone has COVID. We stopped doing asymptomatic screening just to not have as many people in our waiting room, and there's really only a few people showing up per week asking for that service anyway, and switched the routine visits for HIV patients from inpatient to telemedicine. So as you can see, our patient visits have dropped by more than 50%, really. Our community partners did stop doing their STD screening, and as you see, the result is the disease reports have dropped dramatically since the pandemic hit. So does that mean that there's really that much less syphilis, gonorrhea, and chlamydia out there? I don't think so. I think maybe people are having less sex, but I think that there's just likely a large burden of undiagnosed disease, both symptomatic and asymptomatic out there, because people either don't have access to care or are reluctant to come in and get care because of COVID concerns. Next slide. So now we are slowly reintroducing some of the prior services that were deferred. I understand 2 of our 3 community partners will resume STD screening in June. But when will things get back to normal? Who knows? And what will the impact of this undiagnosed burden of disease be? Well, again, I don't think anyone knows for sure, but I think it certainly could have some very significant reproductive health sequelae, particularly around syphilis. So if women are, if women are not getting screened for syphilis, especially during their pregnancies, but even if they're just women of reproductive age coming down with syphilis, that's a real concern. And I think once this pandemic is finally over and things get back to normal, I think we'll see even higher levels of disease once the full services start again. Next slide. So just a few thoughts for community providers about how you can safely deliver or do STD screening. Gonorrhea and chlamydia can be easily diagnosed by self-collected specimens. In fact, the vaginal self-collected specimen is the preferred specimen type for screening of women. So if a woman needs to have a chlamydia test checked because she had chlamydia a couple months ago, you don't want to bring her in, you could definitely either mail them the kit, have them come in, pick up the kit, obtain the specimen at home and bring it back, or do it in the restroom in the clinic. Don't really have to do a full exam to do that. Telemedicine and telephone triage, which many, many places have switched over to. I'm a volunteer with the Lestenac Free Clinic. I had a patient with a rash and the person just took a picture of it and sent it in to me. So that's not ideal, but it's better than nothing. Still, we're having to kind of defer routine preventive services like pap smears for low-risk clients, but certainly for higher-risk clients, someone who had an abnormal pap smear, you don't want to let that go too long. So you want to follow the guidance for symptom screening, social distancing, and masking to reduce potential exposures. I just heard from Dr. Reed, our clinic director, or STD clinic director here at the county, that he had a patient recently with secondary syphilis who was febrile to 101, which can happen in secondary syphilis. We can't send that patient away. So he actually created a private area out in an enclosed patio to be able to examine that patient and do the appropriate evaluation. So in an outdoor setting, probably not available or an option for many providers, but that's just another way to reduce potential exposures when you're not sure if someone has a fever because they have PID or syphilis, or if they have a fever because they have COVID. So I think that's it for me.